I'd like to open it up for questions. If I get a story, I'm going to start with a question with you, boss, just to follow up. I know today we asked you to talk about hepatic artery infusion pump. I was just wondering if you could comment, though, on other local regional therapies, if you think there's any role for Y90. I cited a case where I did use Y90 on that patient, or even is there a role for SBRT to treat patients with ICC? Maybe you can comment on that, and then I'll have a question for Samit.
Yeah, thank you, Tim. Regarding SBRT, our radiation oncologists are typically concerned for liver damage because these lesions are so large typically, so they need a very big field. Often the colon is adherent to the lesion or the stomach is adherent to the lesion, so we rarely use SBRT. We do use Y90, and unfortunately attempts have been done to do randomized trials for this. But what I understood is that they failed to get to complete accrual. The phase 2 trials show some evidence. I think it's not even close as good to hepatic arterial infusion pump chemotherapy, but we do use it in patients who cannot get a pump, or in patients the way I look at this disease is I try to predict what is going to kill the patient. So if a patient has a large lesion that is encroaching on the liver hilum, I think we should do anything to get the liver lesion smaller. And I think Y90 is a good option. If you have a patient with tiny lesions in the periphery of the liver, these patients are more likely to die from peritoneal disease and pulmonary disease. But I think the majority will get in trouble with a tumor encroaching on the liver hilum.
Thank you. I believe Dr. Washington has a question. Kimberly?
Very interested in pump chemo for intrahepatic cholangiocarcinoma. And one of my questions, though, is we've got data for colorectal liver mets and the fact that in those patients, you can get somewhere near to 30% converted to resectability in those patients who are unresectable at the time of pump placement. But do we know that number for intrahepatic cholangiocarcinoma or something similar to it?
Yeah, that's a very good question, Kimberly. Thank you. I probably should have mentioned it in my presentation. So quite consistently, that's about 10%. So that has been about 10% in the studies from Memorial, and it has been about 10% in our study. The thing, though, that is very different, I think, with colorectal liver mets is in colorectal liver mets, you still have a probability, even though small, but it can be 10, 20, 30% of actually curing these patients. And with intrahepatic cholangiocarcinoma, we know that they will all die from their disease. I mean, like Tim showed, even the resectable ones, the cure rate is 10%. And so the ones that are unresectable, they will all die from peritoneal and lung disease. And that's what we see in these pump patients. So to me, the benefit of liver transplant or resection after a pump is very limited because the pump controls the liver disease, and any other treatment needs to deal with metastatic disease. Does that make sense?
Thank you.
Yes, Professor Ramadori.
What question? You showed that the 3-year survival with systemic 5-FU administration is 3%. Can you tell us which kind of, how much 5-FU and how it was administered as a bolus or infusion, and how was the total, amount of 5-FU administered in those studies?
I think I may not have explained this well, or I don't understand your question well. Let me go back to this slide. This is the slide of systemic treatment. And right. This is a subgroup analysis of the ABC trials. And all these patients had systemic GEM-CIS.
Yeah, I mean, 5-FU, the efficacy is dependent on the kind of administration. You know, if you use a pump for 48 hours, you can use a higher amount, higher dose, and get much more efficacy. So if you go back and patients have been treated with 500 milligrams as a bolus, and of course it doesn't work. So the comparison has to be done, you know, with a systemic therapy, with the appropriate dose and the appropriate way of administration. As it's now coming out for pancreatic cancer, for colon cancer, you know, if you use infusion every 14 days, 2.4 gram per square meters, you get a much higher efficacy.
I'm afraid I do not understand your comment.
The question was, you know, those studies where the 3-year survival was 3%, which doses was used for 5FU and how it was administered?
So the slide I'm showing now with the 3-year survival of 3% is not about 5FU, not about fluoxuridine, not about intraarterial chemotherapy. It's the data from the ABC trials about systemic GEM-CIS.
Systemic? Say it again.
Systemic GEM-CIS. So this is a subgroup analysis. So this slide shows the ABC02 trial, right? But this is for any cholangio, including gallbladder.
Okay,
and this slide is a subgroup analysis that the ABC group published. And all patients received GEM-CIS for liver-only intrahepatic.
Okay, then forget it. But 5FU is effective also systemically. So if you do treat those patients with 5FU systemically, it may be as effective as intraarterially, which is an invasive way of treating persons. So it can be effective. Of course, if you have a cirrhotic, if you have ecthetic people with bilirubin about 15, you cannot do it. But on the other hand, you can use capecitabine. Capecitabine, you know, you can give it orally. It could be as effective as the intraarterial treatment. I mean, it was just a comment.
Yeah, maybe we can get Samik into this conversation as our resident expert medical oncologist.
Okay.
Yeah, you know, I agree. I think thinking about, you know, systemic versus local delivery, you know, people can tolerate capecitabine and 5FU systemically pretty well from my point of view, every 2 weeks. On the other hand, the convenience of having a monthly dosing, perhaps of intrahepatic, as well as I think the key feature on this slide, very nice presentation, by the way, is the 200-fold, you know, localized concentration of drug. You could never, you know, if that was the dosing you use for the equivalent of 5FU, that person would never recover their blood counts, right? And so I think that's really the exquisite opportunity for a local delivery. I was going to add a comment. Tim mentioned, you know, other modalities for local non-surgical treatments. You know, as far as radiation, you know, the other modality, I don't often see it because most of my patients come to me with disease everywhere. But when you've got liver dominant disease only that's not resectable, you know, certainly the emergence of proton radiation has become a useful tool. There was a nice study and some smaller, you know, series showing that proton radiation can be well tolerated, pretty good at local control. A handful of people would progress, and certainly, of course, if they're going to progress, most of them progress systemically. So I think that's another important option as proton radiations, you know, become more available. It's quite expensive to build a proton center, but we're starting to see more and more applications, again, with lesser toxicity, which is the chief concern for radiation to the liver, especially big masses in the liver. But I've had at least a handful of patients who've had, you know, more than half of their liver radiated and have done well with proton. So anyway, just wanted to mention the proton radiation angle here. So.
Thanks, Mick. Hey, Smick, I had a question for you. You know, it's been my experience that we typically treat these patients in the pre-op setting if they're unresectable or borderline biologic candidates, kind of with standard therapy first, and then move to kind of targeted therapy, you know, as second line. Can you just talk about like moving some of this targeted therapy forward, and you know, the importance of getting the molecular and genetic data up front, and you know, how comfortable are you now just to like start off with a targeted therapy if we're looking for a response as surgeons to try to get them to the OR?
I think that's a great idea. Treating smaller disease that can be removed is a lot better than treating disease everywhere. And so far, you know, I gave an example today of a patient who had failed GemCis and was still not resectable, and we gave him an FGFR inhibitor. So that's going to be part of a case for a series that we're going to share from that study with three total patients who had a similar outcome where they were able to go to surgery when they were previously not resectable for a reason usually related to anatomy or burden of disease. And I think it's a great idea. You know, we've not yet seen combination approaches with chemotherapy and FGFR drugs. There's a little bit of clinical trial evidence and data out there that's not published, but that's a great opportunity. We know that FGFR drugs plus GemCis can be tolerated. And so you know, if you have a patient who's positive, I think it would not be unreasonable to try, if you're trying to get that partial response, to get them to a safer and better or feasible resection. Absolutely, I'm very much in favor. You know, again, these are rare cancers to begin with, and we may not have a study yet of GemCis FGFR for neoadjuvant therapy, and we may not. You know, the current studies for first-line therapy, randomizing patients to chemo versus FGFR, they're struggling to recruit patients across the board. And part of it because of the delay in therapy. For in that type of metastatic disease setting, people are worried about, you know, the disease burden and delaying therapy. And so those studies have struggled. But we've already seen evidence that the combination is safe. So I think if you have a patient who's marker positive FGFR, for example, I think it'd be a great idea to include it all at once to get them their best chance of surgery. Very much in support of that. So
thank you, Boss. We're at time, so one last brief comment from you.
Yeah, just a question to pick on your expertise of Samik and Tim. So if you have a patient with FGFR rearrangement with a huge response on targeted treatment, young fit patient, the liver, all the lesions much smaller, but there's one aortocaval node that's now 8 centimeters, and it's the only lesion that's growing. Would you take it out?
The node is 8 centimeters? That's a big node.
It's an 8 centimeter aortocaval node, and it's right at Treitz ligament. It's at the left renal vein. So it's going to obstruct the duodenum, and all the other lesions are much smaller.
So if this is a real patient, I would try to get a biopsy or try to do a liquid biopsy assessment, and maybe they could be switched to one of the second generation FGFR drugs. If there's a resistance mutation, if there's not a resistance mutation, but they may have acquired something else. So we've seen, you know, BRAF, PI3 kinase that could also be co-targeted with an FGFR drug. So something's goofy with that lymph node, and it could be, you know,
it's taking it out.
Yeah, and I would try to biopsy, liquid biopsy, and try to treat it systemically at 8 centimeters. I wonder if there's more disease than that one lymph node.
So just we have to wrap up. So I agree with everything Samik said. So I think looking for some type of other targeted mutation, right, for second line therapy that you could use, and I would proceed along that way. I think I've already demonstrated in the patient I showed with the super large tumor and the ascites and the CA19-9 over 100,000 that I have an appetite for taking people to the operating room if they've had like a good response from chemotherapy, even though we know that, you know, their prognosis could be guarded. But, you know, frankly, if you can do it safely and they've had a good response otherwise, boss, you know, I probably would, I would do it.
You could also follow the systemic therapy after the surgery. So get the lymph node out, test it, and you could tailor the adjuvant therapy accordingly and continue an FGFR drug if you think there's risk for recurrence too. So,
Professor Vardy, this is a robust discussion. I don't want to cut you off. So if you have a brief comment. I don't know. Hand up.
Yes,
yeah, Professor.
I have some question. Yeah.
Okay, Feng, how about let Professor Vardy go and then I'll get to you. Did you, Professor Vardy, are you there?
Yeah, I am here.
Very good. So I have some question about the systemic for ICC, because my question is about Lloyd Hurry about the, you know, what is the opinion about the TKI in ICC, because, you know, we have a nationwide study to discover that the birth ICI plus chemotherapy, GC, or plus TKI or anti-vascular agents can achieve a similar survival benefits in advanced ICC. So because, you know, there was very, very little studies on TKI on ICC, even for BTC. So what's your opinion about that?
Smeek, do you want to comment on that?
So could you,
I think it's TKI.
Which TKI was that? I'm not.
Yeah, TKI, Lenvatinib. Lenvatinib is most commonly used. Yes.
Yeah. So, you know, I'm not familiar with the study, but I'd be very interested to hear more about it, maybe offline. Lenvatinib, you know, is one of those weaker FGFR drugs and has other activities. So it'd be interesting to see its efficacy. But I apologize, I'm not familiar with the study. But I'll pass it back to Tim as the moderator.
Okay. And then Dr. Vardy, just one last brief comment, because we really do need to wrap up. I know
just keep it for the want of time, very brief. Yeah,
okay.
So I just wanted to know your thoughts on preventing futile resections in IHCCs and also the perihilar cholangios. So we assessed our data for last 10 years of about 180 resections, and we found out quite a bit of number of 20 to 30% do recur in early 3 to 6 months. So any predictive preoperative parameters, models to assess to prevent such futile resections?
Yeah, so I guess just briefly, you know, I think I highlighted, I think it's a little bit different. In my mind, I think for intrahepatic cholangio, frequently it's futile because of biology. You know, you're technically able to do the operation, but the patients recur. So I think of biologic futility, if people have a large tumor burden, if they have multifocal disease, if they have evidence of lymph node metastasis preoperatively, I think the chances that you're going to derive a long-term survival benefit are probably lower. So I'm going to work with Smeek to try to come up with a multimodality approach to that patient. I think for perihilar, it's different. Frequently, you know, it's hard to tell whether they're truly resectable or not based on preoperative MRI, even ERCP or cholangioscopes, et cetera. So that's more of a technical issue, in my opinion. You can be challenging when you get in there. There may be arterial involvement, venous involvement. So those patients, I don't use a lot of preoperative chemotherapy. You know, I just use, you know, MRI, MRCP, spyglass, and then if it looks resectable, I'll try to resect them.